So we spend so much time on venous thrombosis. It is common than other types of stroke, and it's also more challenging to diagnose. So it's worth talking about at least a while because it is a cause of stroke that, while rare, is important and should not be forgotten. And most critically, it has a very different treatment course than other types of stroke. In the United States, the incidence is between 2 to 7 cases per million population per year. It's a fairly rare disease, but at large centers, I estimated that there are about 5 to 8 cases annually. So it comes up often enough that it's worth bearing in mind. As I said earlier, this disease is most common in the neonatal population, even though I showed you a case in an older adult. It really affects younger children much more often than it does adults. In children, outside the neonatal period, it also occurs. It's much rarer than it is in neonates, and it's less often seen in the adults. The mean age is about 39 years, so it's younger than most other forms of stroke. A minority of patients are older than 65, as interestingly in the case that I showed you. There are a couple of important risk factors to remember as you think about the clinical history of the patients who are presented and might have this disease. Trauma to the head affecting the venous sinuses is an important risk factor that includes surgical trauma. But any kind of trauma that causes an impact to the head at the cranium, application of the venous sinuses can cause thrombosis. It's particularly associated with fractures of the overlying calvarium. When you have, for example, a occipital fracture, it can impact the lateral sinuses and cause thrombosis in the sinuses. So when you see a case of head trauma with skull fracture, it's important to think about whether there's an underlying venous sinus problem. Infection is another risk factor. Especially in children, it's important to remember mastoiditis and inner ear infections, which can be linked. So if you see an infectious process involving the mastoid air cells, it's again important to pay special attention to the adjacent venous sinuses, because the inflammation associated with infection in those areas can precipitate thrombosis in the cerebral veins. Pregnancy is a hypercoagulable state and also associated with venous sinus thrombosis. It's one of the reasons that the demographic distribution of this disease skews young. As oral contraceptives, which especially estrogen-containing oral contraceptives, are hypercoagulable. Pregnancy, as we said before, can lead to a hypercoagulable state. Dehydration and any other cause of thrombophilia really can increase the risk for this disease. This includes, for example, iron deficiency anemia. In about 25% of cases, we just don't identify a cause, and we assume that it's due to a combination of dehydration, some other cause of hypercoagulability, a minor infection. Sometimes we don't know the exact proximal cause. Where does the thrombus occur in this disease? I think the bottom line is actually the bottom line here. The last line on the slide is that patients have thrombus in multiple locations. But if you see isolated thrombosis, it's most likely to be in the superior sagittal sinus. So that's the sinus. No surprise, it's the largest sinus, so it's the sinus that is most often involved. But oftentimes, there can be extensive thrombosis that extends not only through the sagittal sinus, but through the confluence of the sinuses into the transverse sinus. So those co-involvement of those two sinuses is also fairly common. Involvement of the sigmoid sinus, so that means the sinus usually will the thrombus usually will extend from the transverse into the sigmoid sinus. That is relatively rare. Venous system is so involved a little bit more rarely than the superficial venous system. And cortical vein thrombosis is to be pretty rare in this disease. This low number may also reflect the fact that cortical vein thrombosis is more difficult to diagnose than the dural venous sinus thrombosis. Clinically, there are a couple of important facts to remember about the clinical presentation, but one basic fact is that it's really variable. Most patients have headache in this disease. That's really the one common theme. In the classical literature, there are sort of three syndromes of venous sinus thrombosis. One is a syndrome of intracranial hypertension, and intracranial hypertension is really caused by impairment of venous drainage, which leads to increased pressure in the intracranial compartment. So those patients have headache, sometimes with vomiting. They often have papilledema, and they often have visual problems, as you see with intracranial pressure of all classes. They have a focal syndrome, and this may be due to focal edema or hemorrhage. So they may have focal neurologic deficits or seizures. And finally, some patients have an encephalopathic presentation. So they just appear to be confused or sleepy. They have variety of neurologic signs or mental status changes. So as you can see, the clinical presentation can be quite variable and quite confusing. So another reason it's important always to keep in mind this potential diagnosis. The most common used imaging modalities in the U.S. for have easy access to MRI are MRI and two-dimensional MR venography. Really, the best non-invasive imaging technique for this disease is CT venography, if you have access to it. It's rapid and more accurate for reasons that I'll show you than time-of-flight MR venography. Venography with gadolinium is probably equivalent to CT venography, but it is often used, at least here. Common screening test is head CT, and sometimes that's a screening test that is, as you know, in the emergency department or in the sort of in a first pass before the treating clinicians actually know what they're looking for. This is a tricky test for venous sinus thrombosis. In about cases, the head CT is normal. Sometimes in retrospect, you can identify subtle abnormalities, but in about a third of cases, it's called normal initially. In another third of cases, it is equivocal. There may be subtle abnormalities that are not diagnostic of this disease. And the remaining third of cases, which obviously is a minority, that you can make the diagnosis of venous sinus thrombosis just from the non-contrast head CT. There are a couple of signs, which I'll show you in the next few slides, that are very pathognomonic for this disease. Empty delta sign, the empty triangle sign, the dense triangle sign, and the third is the cord sign, which is specific for cortical vein thrombosis. And I'll show you images of those in a moment. As you can imagine, that the third of cases, a third of CTs are equivocal. There are a number of non-specific signs that might lead you toward thinking about this disease. One, small ventricles, as you see in other causes of intracranial hypertension, ventricles become compressed. So if the ventricles are smaller than you expect for the age of your patient, it might be a clue. Tentorial or falcine enhancement is another clue. So again, this is due to venous congestion. So as I told you, the sinuses are formed by invaginations of the dura, the whole collateral venous system that provides for drainage in case of sinus occlusion or thrombosis. And those smaller veins draining into the sinuses become engorged you can see strong enhancement of the structures, especially the tentorium and the falx. Hemorrhages are another sort of secondary sign of venous sinus thrombosis. So there's a lot of venous congestion that can lead to rupture of cortical draining veins, causing hemorrhages. Obviously, there are many other causes of intracranial hemorrhage. This is just one. But if you see hemorrhage in some of those venous drainage distributions that I showed you, especially if it's sort of patchy and perhaps multifocal, venous sinus thrombosis is an important disease to think about. Again, edema, a very nonspecific sign, but edema in one of those venous drainage territories might clue you in to this underlying cause of disease. Infarcts are a very interesting phenomenon because, like infarcts caused by an arterial embolic stroke, the infarcts can vanish on repeat imaging. By vanish, I mean signal changes associated with those infarcts can disappear. Those signs that I told you about just a moment ago are on non-contrast head CT, I believe. The cord sign is a specific sign for cortical vein thrombosis. So this is not a major venous sinus, but a smaller cortical vein, and you can see it's hyperdense CT, which indicates thrombosis of this cortical vein. The dense triangle sign is again a hyperdensity, but in one of the larger directors, which have a triangular section, and again, this indicates sort of fresh within the venous structure. And the so-called empty delta sign, which again is the triangular profile of the sinus, but here you have a flow void in the middle, or in hypopotensity in the middle of the sinus, which occurs a little bit later in the evolution of this disease when the sinus has started to So the empty delta sign is the most famous and the most commonly seen CT sign. As I said, this is observed only in the subacute phase. So in the acute phase, if you see anything, you're more likely to see the dense sign. But beginning at about 5 days and peaking at about a week or 2 weeks out, some recanalization or reorganization of the thrombus, and you start to see this this partial filling of the sinus around the thrombus. May represent dilation of the collaterals around this lumen, where you can see the filling around it. This, in contrast to the previous images, this is a CT venogram with contrast. So this is filling around the void representing thrombus. Venography by unenhanced time of flight or enhanced with gadolinium are often used. Contrast-enhanced MRV is really preferred because it improves the visualization of the small draining vessels and the depiction of the dural sinuses. You can also see thrombus on the MRI images, and there are particular signal characteristics of the thrombus that can tell you something about how old it is. So less than 5 days, the thrombus is T1 isointense, T2 hypointense. Between 5 days and a month, so the time period where on CT you're likely to see the empty delta sign, thrombus is T1 and T2 hyperintense. And more than a month out, the signal patterns can be variable. Two star-weighted images or susceptibility-weighted images can directly visualize the clot as an area of hypointensity, as I showed you on some of the previous slides, although there you have to be careful because slow flow or sort of stagnant flow in the sinuses or in cortical veins can also appear as T2 star weighted intensity. So this is, again, the susceptibility image from the patient's case I presented earlier. So there is some T2 star weighted hypointensity in the structures adjacent to the left transverse sinus, and those could represent extension of clot or slow flow of venous blood. The case, and the intention here is to illustrate the progression of findings from the acute phase to the chronic phase. So this is actually a 2-month-old child, so a more common age for this disease to present. And in contrast to the previous case, where involvement was of the major dural sinuses, this child had extensive thrombosis of the deep venous system. So in the first panel, labeled panel A, is a susceptibility weighted image showing clot and decreased flow to the sort of medullary venous system and internal thalamic vein on the left. And corresponding to these thrombi, there are areas of venous infarction. So this is a diffusion weighted imaging, where you can see infusion signal owns the areas of infarction. Here's an infarct more in the deep left frontal white matter, in the right frontal subcortical area as well. And as I said, some of these infarcts can resolve, but especially in children, they may also evolve to encephalomalacia. And in this case, what we saw in this child on imaging a couple of months later, cystic change. So these areas of cortical white matter kind of melt away and are replaced by fluid-filled cysts, which appear bright on T2 weighted MR imaging. Finally, I wanted to say a little bit about MRB and transverse sinus thrombosis. This is a technique that is commonly used here, as I mentioned, for diagnosis of venous sinus thrombosis. As the time of flight MRV, because it's relatively easy to obtain, you don't have to administer contrast. But it can be tricky, especially when you're considering the diagnosis of transverse sinus thrombosis. So in the transverse sinus particularly, you can often see artifactual flow gaps in about a third of subjects who actually turn out not to have thrombus. Intra-observer agreement is to whether or not there is disease in the transverse sinus is quite poor. So if there are symptoms that localize to that distribution, or symptoms that don't localize, like headache and papilledema, you see something in the transverse sinus on time-of-flight venography, it really needs to be confirmed with other imaging techniques. So this is a patient of mine, a 15-year-old boy who presented with headache and papilledema. On his time-of-flight venogram, it looks like there's absent filling of the left transverse sinus. You can see here's the, again, the superior sagittal sinus, the straight sinus draining through the torcula. It looks like there might even almost be some decreased filling of the right transverse sinus, but it reconstitutes pretty quickly and drains into the sigmoid and jugular vein. And then it looks like here on the left transverse sinus that there's absent filling. So this image was obtained on the outside, and the patient was referred to me for possible transverse sinus thrombosis. We actually repeated this venogram with gadolinium, and what you can see here is that this flow gap is entirely artifactual. So if you administer gadolinium, you see is normal filling of the left transverse sinus. So this has something to do with the, with the plane of imaging and the technique used for reconstructing the sinus, and the fact that the flow is in the axial or horizontal direction. Time of flight MR venography is really not a particularly good method for imaging the transverse sinuses. So if you see something there, it really behooves you to follow up using another imaging technique. The other thing to bear in mind is that many individuals have an asymmetry in the venous system. So it's very common to have a relative hypoplasia of one transverse sigmoid sinus compared to the other. Oftentimes, in those cases, you still see some filling, even on time-of-flight sonography, but you might question whether there's an occlusion or stenosis. And the clue there is that the entire system on that side looks smaller than the corresponding side. The prognosis for these patients is different than for arterial infarcts. Venous infarcts, if they're treatable, may be reversible, and the treatment really for venous infarcts is removing the clot by anticoagulation. And this is an important point for the clinician, the treating internist or urologist, is that if venous sinus thrombosis is present, then it's anticoagulation, even if there's hemorrhage, because the cause of hemorrhage actually is the clot. So if you remove the clot or if you facilitate dissolution of the clot, you actually reduce the venous pressure, which is the primary risk factor for hemorrhage. The prognostic factors are the site and number of occluded veins. So you can imagine if there's pan-sinus involvement, that's prognosis. Then if there's an isolated sinus involved. Presence of parenchymal lesions, so the presence of infarct or hemorrhage is to a little bit poorer prognosis than if there's isolated thrombosis without parenchymal involvement, and older age is associated with poor prognosis. So in younger patients, the vast majority recover without deficits. In older patients, only about half recover without deficits. And another important fact to notice is about a quarter of the patients with this disease end up passing away due to uncontrollable hypertension. And this is really why it's important to recognize early and to treat early as possible. In the case that I started out with, he was treated with anticoagulation. He was initially on a heparin drip and then was transitioned to warfarin. And he was also started on acetazolamide for lowering of intracranial pressure. He continued to have a headache, but it got better over time. He had a CT diagram a couple of months later, which showed that the thrombus was essentially stable in size. On